Great. So like I mentioned, there's three different areas that we're kind of looking at in ED improvement here. The first is ED throughput. The second is diagnostic accuracy. And the third is transitions of care from the emergency department. So I'd love to talk about ED throughput first. And ED throughput can be seen in a variety of different definitions. And I'd love to share a poll here to see what how you all are measuring ED throughput. So it should have come up on your screen. So do you measure ED throughput via like patient wait time? Do you measure it for time of arrival to time of departure discharge, which is that aligns with that outpatient 18 measure for outpatient quality reporting for CMS and is part of the MDQIP program for cause? Or do you measure time of arrival to diagnosis, or do you look at a variety of things rather than just looking at one piece of the patient continuum through the ED? Do you kind of look at the different areas to see where there's could be improvement? And if you use a measurement that's not listed here, I'd love to know what you use in your hospitals. So please put that in the chat. So it looks like we have I'm going to end the poll, sorry about that. The majority of our hospitals on the call measure that time of arrival to time of departure, discharge, or a mix of all of the above. That is really helpful information to know. So as we're looking at ways we can help improvement, we can narrow in on those things that are most important to hospitals. So now that we kind of know where we're looking at what on our throughput measurements, I would love for our hospitals on the call to unmute or share any challenges and successes to improving that length of stay in the emergency department while still providing high quality patient care. So what have you found that has improved the throughput of the patient to the ED so they're not there for extensive amounts of time, but still providing that high quality care? And as I hope folks are typing, or like I said, you can unmute, the calendar year 2022 national median time in critical access hospitals for that time to arrival to discharge was 115 minutes. So that's a little under 2 hours. And in addition to the question, what is your goal for that time? What is your ED throughput goal when you're looking at your data and how you want your patients to come through the ED? So do you guys feel that, oh, thank you, Kate. Kate has commented, she would like her goal to be 4 hours, but on a good day, the facility ED throughput is 6 hours. So what do you guys think are the barriers that come up in your facility to your goal ED throughput times? What are the things that are preventing you from meeting those goals or make it more difficult to meet those goals?
So this is Dawn. I kind of agree with Katie. We're critical access, and so there's less transportation for patients who don't have a ride home and they don't want to leave your ED. They want to wait in there. We also struggle with keeping staff or being understaffed. And so if you're short on nurses or short on techs, that also increases our times at our facility. We don't really have provider issues, but so we have physicians and nurse practitioners, but at night we have night hawk radiology readings, so that increases your length of stay. And then usually radiology doesn't arrive until like 8 a.m. So from 8 to 4, our rad times are okay, but anytime outside of that, it can be a little hairy on getting reports back.
Thank you so much, Dawn. And I think I love the comments you made about kind of the piece of outside of the hospital, the transportation, patients being able to get home, and radiology is a big issue. Not that they're doing anything wrong, but that just the way things work, it's the amount of time it takes to have things taken care of. In the chat, we have comments on bed availability, having provider staffing, and Dawn touched on that too with the nurse staffing, radiology reports, and Kate agreed that bed availability to see patients, and then lab and radiology is also a barrier. Thank you. Has anyone on the call been successful in taking those barriers, whether it be bed availability, transportation, staffing, or lab and radiology, and improving the process or improving the situation so that the ED throughput times for patients are less, or there's less wait times?
So I'll comment again on the bed availability. When you transfer a patient, what we've done at our facility is we've partnered with one of the larger organizations. They're about 35 minutes from us, and like we have an agreement, I guess. And so depending on the situation, they're like we don't have to. So if it's a STEMI or a stroke or PE, we have numbers that we can call, and it's like auto acceptance, and they call us back fairly quickly for a bed. And it's kind of like, since we're a partner with them, we kind of get first preference. So instead of being the last person on their list, it's kind of gives us a little more advantage with that partnership with them. So that has helped with the transfer length of stay with door to discharge, but the rest of it, I have nothing.
That's a great idea, though, harnessing those partnerships where you can. If you have a tertiary facility that you are transferring patients to frequently, working with them to, look at what are different ways that we can make this more efficient on their end and on our end, and have a partnership. That's fantastic. Mandy commented that our nurses are drawing blood for labs now to help the minimal staffing in the lab. Yes, are there any other out of the box staffing ways we can do? Is there things that some other staff can take off the plates of those where there is minimal staffing? Has anyone had any successes in working with radiology and radiology staffing and the resources we have after hours to help improve getting those results back more quickly? At Amanda's facility, they have trained our ER techs to do IVs and blood draws. Awesome. That takes some time, or reallocates time from nurses. Great, thank you. And Kate, we've outsourced our radiology reads for 24/7 coverage, but there are still delays in results. So in a perfect world, I know like with radiology, it takes time to go get the image and then have it read by a radiologist. What is your ideal time frame for that process? In a perfect world, how quickly, realistically, with the steps in radiology, would it take to get your radiology test back.
So our goal here, as long as like they're not a stroke patient, from the time it's completed until the time we have results, we would like it to be an hour.
Awesome.
That doesn't include the time that it takes the tech to do the actual imaging or anything. The time starts from when it's complete and sent to when we get results. We want that to be an hour.
Awesome. Thanks, Dawn. Anybody else? What's your goals and have you met those goals? Mandy's facility, their goal is 45 minutes. And meeting it sometimes. Thank you. It's really helpful to have an understanding of like the realistic expectations within the facility, so we have something to move towards, like that goal to look at. Does anyone have, before we move on to the next topic, does anyone have any other challenges or successes in anything that involves the patient experience, not the patient experience, but that patient throughput in the facility or in the emergency department? Have you done anything that helps increase the patient care, increases their the timeliness? I'll give kind of a last chance for input and sharing, or if you have questions for other hospitals that are on the call, this is a great time to do that too. I'm going to move on to the next component of what we're looking at with emergency department care. But if you think of anything after the call, please feel free. My contact information will be on the slides. Please feel free to shoot me an email. If you have thoughts or questions or just ramblings like I usually do when I wake up in the middle of the night, I'm like, oh, and try to think it through. Please feel free to shoot me an email. Anything that you can provide as context of information can really help give us this picture of what our hospitals are experiencing and now, what the barriers are and where we'd like to go and how we might be able to combat some of those barriers. So our next component that we're looking at here is diagnostic accuracy. There's some studies out there and they found that there's instances of inaccurate diagnosis in the ED are kind of high, about as much as 5.7%. And so we know that there is a lot of components to this. And so we're hoping we can identify some ways that we can help prevent inaccurate diagnosis or help make that better within the facility. So what has your experience in your facility been? Is your experience in your facility that high inaccurate diagnosis rate? Or are you not really seeing that in your hospital? It's kind of a pulse check. Thanks, Zoe. No issues at Zoe. And Mandy's not saying too much of it. And not an issue. Sir, we Tabitha's hospital has had some issues with CVAs. Okay. So it kind of sounds like this isn't really, even though like there's research in our rural hospitals, this really isn't an issue that we're seeing much. And if it is, it's specific to a certain factor. Zoe, I don't have the document linked here right now. I think it's probably most likely larger hospitals. I know I did talk with some patient and family partners in the patient family partner hub that we work with, and they gave some good insight of what their from their experiences where there might be some inaccuracies in diagnosis. One was the ability of the patient or caregiver to provide an accurate history and physical. Um, one patient experienced a lot of implicit bias based on her age. The in the older community, in the older generations. And then also insurance, if we have one diagnosis that there's more procedures covered by insurance. Those are some things that are factors that we've seen. Um, some operational factors within your hospital that I'm curious, like with telehealth being so not popular, but being used so often. Is there any challenges with those providers with inaccurate diagnosis? But my gut's kind of telling me, and you guys can let me know if I'm off, that this might not be as big of a occurrence in our rural hospitals because it is smaller. We have a little bit more time with our patients. We know our patients a little more. There's just kind of some things in that smaller realm or in that smaller environment that we can have control over. And we don't, those typical impacts of an accurate diagnosis don't really come into play. And if that's the case, that is something that we would really love to share with funders and CMS as to supporting that quality of care in rural hospitals. Like there are issues that bigger hospitals experience that we might not be seeing in rural hospitals for a variety of reasons. So I am going to jump to the next topic since that isn't really an issue for our folks on the call. And the next topic is on care transitions. So I'd love to hear, leaving open-ended, about your experiences transitioning patients from the emergency department to home or another care setting, any challenges and successes, anything you're seeing that might be bringing them back to the bringing them back to the ED. Transportation, yes, thank you, Mandy.
I would just say I agree with Mandy because even if you can get them transported home, a lot of times you're going to get repeat visits or readmissions due to the fact that they can't make it to a doctor's appointment to follow up. And then food insecurity is also an issue here as far as why they come back, diabetics that aren't eating correctly or people who just don't have correct nutrition come back with more issues than what they had when they left.
Absolutely. As kind of a side question, I know that their social drivers of health, which include food insecurity and transportation, are being screened on inpatients or starting to be screened on inpatients. Does your hospital screen this at emergency department visits as part of the intake?
So
Yeah.
I'll answer that as well. Currently, we are in the process of figuring out which questions we're going to ask because down in the ED, obviously, we're trying to decrease the length of stay, not add to it. And our screening tool that we have with our EHR is pretty lengthy. So we've talked with other critical access facilities, and they have like a 5-question screening that they do that we're going to start implementing before the end of this year.
That's really awesome, Dawn. Thank you. Yeah, if like those inpatient screenings, if there's ways we can narrow it down into things that we're seeing that might be most impactful for ED visits and return visits and having accessible transfer out, that's great that if we can screen it and be ready.
Yeah, what we did was we actually used our inpatient screening tool and picked a top 5 issues that we were seeing inpatient wise. And that's how we picked our top 5 questions for the ED.
That is a beautifully simple way to do that. That's going in our best practices for sure. Thank you, Dawn. So has anyone been able to have community partnerships or institute programs or try things to help improve the food insecurity when they're leaving, making sure they have meals that fit their dietary restrictions or even transportation, like follow-up phone calls after the ED, making sure that they are able to get to a follow-up appointment. Is there anything that your hospital has been doing to help address some of those barriers? So I'm going to share, Tabitha has a comment in the chat. Bed availability at other facilities is challenging at times, and we've seen our throughput times with our psychiatric patients improve due to our facility starting an in-house behavioral health unit. Yes, there's another, thank you for sharing that, Tabitha. There's another concept is, are we seeing our throughput times and our transitions and those kind of things be within like certain diagnosis or certain types of patients? Like, is it mostly in our psychiatric patients? And then we can look and maybe support ways that the facility can offer additional services or help bridge that transition. And Tabitha also shared that our screening tool for SDOH is complete with inpatients, and we are working on incorporating this in the ED and hoping our new ED case manager will help tremendously with this. Oh, that's awesome. You have an ED case manager. Who else has case management staff to help with transitions from the ED and ED discharges? Kate's Hospital, they have 3 during the day and 1 at night. Thank you. I want to share some insights. This topic had a lot of discussion with the patient and family partners group, and they provided a really amazing perspectives to help remember. And I'll just kind of share with you, and if you have any thoughts or reactions related to the screening and the social drivers of health that include the transportation and food insecurity that we just heard about. The patient and family partners really supported thinking about them as a whole person and making sure that when they leave, that they are safe. They have a connection point with some, like a caregiver or a loved one if they're by themselves, and that they have everything they need to have a safe place to land. And one of the things, I have quoted is they said, and this I think ties into care transitions. They said, "You're missing talking to me and telling me what is next." You're seeing me at my very worst, and here I am with all these people and not knowing what's going to happen next. So having that clear communication about next steps and expectations can really help the patient through the ED ED length or care stay. So does anyone else have any interventions that you do in your facility for transitioning out of the emergency department, either to home or another care setting? Do you do follow-up phone calls with your ED patients, or even just a percentage of like those that might be a high risk for return, or anything like that? What do you feel like in your facility helps your patients transitioning out of the emergency department? Well, if you guys think of anything, please feel free to share. And sometimes it might be the smallest thing that you're doing that might have an incredible impact. And so we'd love to hear the different ways that our hospitals are tackling all of these different components of ED care, making it better for our patients, making it more high quality and safer. So anytime, like I said, please feel free to shoot me an email, or give me a call if you have any thoughts. So we are doing a repeat session of this, same questions, just wanted to offer a couple different times um, to kind of encompass availability. So if you would like to come back, we would love to have you. We might hopefully you'll hear from also some other hospitals that weren't able to make it today, but we will meet next on August 6th. If you know anyone else at your facility that would be valuable to attend, or might have some great perspectives or information to share with us, we'd appreciate it. If there's anything that we might have missed in what we're looking at for ED improvement that you think is important that we didn't talk about, I'd love to hear about that also. We have some tools and resources that we are updating, and we want to make them as meaningful and applicable and relevant as possible. So before I let you guys have your afternoon back, is there any other thoughts, comments, or questions on some of the work that or some of the stuff that we talked about today, or stuff that might have been missed? Okay, hearing none, I will wish you all a great day. My email address is jwagner@convergencehealth.org if you would like to reach out to me. And please have a wonderful day and a wonderful week. And I really appreciate your time and those and sharing and being willing to have discussions with us. So thank you so much, and we will talk soon.